be talking on the surgical management of cataract and coexisting glaucoma. We all know that cataract is the commonest cause of blindness, and also glaucoma is the second leading cause of blindness. With aging population, the incidence of coexisting cataract and glaucoma are on rise, and we are seeing more and more patients with existing cataract and glaucoma. Uh, we know that trabeclectomy does well with glaucoma surgeries. Cataract does well. We have excellent results with phacoemulsification. Combining phaco with trabeclectomy becomes an obvious surgical choice for coexisting cataract with glaucoma. Uh, some people prefer doing just phacoemulsification for existing glaucoma and add topical anti-glaucoma medications. But this condition slightly is difficult for Indian scenario, because with the elderly population, the compliance with medications becomes slightly poor. It is difficult for the patient to continue putting topical anti-glaucoma medication after phacoemulsification. So we see that patient loses interest in topical anti-glaucoma, he loses for follow-up and ends up with being blind. So that's the reason why we should be planning and combine trabeculectomy with cataract surgery. What are the surgical options for this condition? We can do just cataract alone if there is early glaucoma and the medication pressures are controlled with just one topical anti-glaucoma medication and there are hardly any disc changes and field changes. We need to do cataract with trabeculectomy when there is advanced glaucomatous damage and the IOP is uncontrolled with medications. And more recently, we are able to add the mixed procedures, that is microincisional glaucoma surgeries, to cataract in patients who have mild to moderate glaucoma and they're open angle. So when do we plan just cataract extraction alone? Cataract extraction alone can be planned in phacolytic, phacomorphic, and phacoanaphylactic glaucoma, where you can just do plain cataract surgery. If you want to do SICS, you can use superotemporal area for SICS and leave the superonasal quadrant for future trap if required. You can, in mild angle closure glaucoma, where there is hardly any disc and field changes, you can straight away go and do cataract. So there are some talks regarding early lens extraction, or there are consideration regarding early lens extraction. You should consider this with caution. It should be done when the anterior chamber depth is less than 2 millimeters, lens thickness is more than 5 millimeters, and there is a high lens vault of more than 1 millimeter. So for that, you may need an UBM to be done, or anterior segment OCT to judge whether there is high lens vaulting. This causes IOP reduction in 4 to 8 millimeters. The IOP reduction with just phacoemulsification is approximately 4 to 8 millimeters, but it is short-lived. And there are studies which say that the rise in IOP is noticed after 2 or 3 years following the surgery. So coming back to the original topic, that is combined surgery, the visually significant cataract, uncontrolled IOP on single medication is the indication for phacotrabeculectomy. Also, the patients who are non-compliant on topical anti-glaucoma medications or have difficulty in instilling the topical anti-glaucoma medication. Phacoemulsification with trabeculectomy doesn't come without complications. Basically, these are always quite difficult surgeries. Why? Because most of the glaucoma patients are having non-dilating pupil because of chronic use of miotic or pseudoexfoliation. They are associated with weak zonules because of PXF or trauma. The poor endothelium count, high fluctuations in IOP is associated, very well correlated with the poor endothelial count. They are associated with shallow AC, and there are high chances of existing pus, especially in post uveitic cases. So when you are planning a phacotrabeculectomy or combined surgery, be ready with all these gadgets. Like you need to have an iris hook, lens hook, CTR, Sionis ring, high cohesive viscoelastic, dispersive and cohesive viscoelastics. So we need to take good care before and being prepared for a surgery. So typically phacotrabeculectomy will involve Okay, so I'm going to show you a short video of phacotrabeculectomy. I do a two-port phacotrabeculectomy, a superior incision for trabeculectomy and temporal clear corneal phaco. A conjunctival peritomy is very important, vital to not damage the conjunctiva while doing the dissection. Scleral flap, I prefer doing a rectangular scleral flap. Try to make it as uniform as possible. It should not be very thin or not be very thick. A thick flap is associated with early failure and thin flap with overfiltering bleps. Incomplete side extensions are done. Incomplete site extensions enhances posterior drainage of the aqueous. Mitomycin needs to be applied over a larger area so that there is a diffuse posterior elevated bleb. More the posterior the bleb, better it is. A thorough wash of mitomycin C, and then phaco is followed through a temporal tunnel. Temporal entry to side ports, standard phacoemulsification within the bag IOL implantation is very critical. Now go back to your trabeculectomy site, make the entry, do a proper Kelly's punch is used to do trabeculectomy. Peripheral iodectomy is done, and then the scleral flap is sutured. You can suture the scleral flap using 10-0 nylon suture. It can be an interrupted suture and releasable suture. Releasable suture gives us an advantage of placing a tight releasable suture, which you can remove in the immediate post-operative period, depending on the intraocular pressure and the way your bleb is forming. After doing the releasable suture, it's extremely important that we put a proper conjunctival suture. Making a watertight conjunctival suture is equally important. So that is the phacotrabeculectomy. And then more recently, now we are talking of MIGS procedures or combining our phacoemulsification with GAT surgeries. There are a lot of reports saying that the results are good. It has advantage of lesser post-operative complication, faster recovery. It is as good as doing a phacoemulsification, but there are some chances of having hyphema afterwards. It is preferred to be done in open-angle glaucoma, mild to moderate glaucoma. In pseudo-exfoliation and pigmentary glaucoma also, you get good results. So which is the case that you will choose? The above two pictures are the places where you will choose to do a GAT with phacoemulsification. So the angles have to be wide open, and you're supposed to see the Schlem's and all the trabecular meshwork clearly. This has to be done before starting the surgery. So once you're sure, it's just another minute. Just a minute.
You have crossed 1 minute more from allotted time.
So this is, we do complete a standard phacoemulsification, and after completing the standard phacoemulsification, we go ahead with the GAT surgery, where MVR blade is used to make a slit incision in the Schlem's canal or at the area of the trabecular meshwork. A 6-0 proline suture is passed. A humped 6-0 proline suture is passed, and approximately 20 to 30 swipes are taken, pushes are done, and then once you notice the proline suture coming out from the other side, it is pulled, the Schlem's canal is opened, a slit incision in the Schlem's canal is done, and the free end of the suture is grasped with the intraocular forceps. Why I'm not getting? Okay, thank you. So the preliminary results are good with phacotrabeculectomy with GAT. I think we have good results for mild to moderate glaucoma, and everyone should try learning GAT. That's what I want to say. And also phacotrabeculectomy. Thank you.
Thank you, Dr. Pooja, for wonderful videos. A comment from panelist.
I would that specifically angle closure eyes doing care of proper IOP control before planning for surgery, and they should have a give a preocular post block massage is important, and if there is any high pressure fluctuation suspected, then especially plateau iris pre-op injection mannitol also helps.
Yeah, all those preoperative regulations that we need to follow for any trabeculectomy or phacotrabeculectomy are valid for all these surgeries. So if there is high pressure, as a standard protocol, we should start acetazolamide at least 4 to 5 days before the surgery. On the day of surgery, give mannitol, see that the eye is really soft, give a proper peribulbar block, and then go ahead with the surgery. This is a standard protocol that you need to be following for all your phacotrabeculectomies. Yes.
Just to add on to that block part, I think subtenance is becoming a very good choice for glaucoma surgeries, and I'm sure many of us do topical as well, but then if topical is uncomfortable, subtenance has been an excellent choice.